Bismillahirrahmanirrahim. Today's our pair teaching presentation. Here present of my honorable instructor in charge, Musammad Hasina Momotaz ma'am, my respected class teacher Husniara Khatun ma'am, Rohima Khatun ma'am, Munjuara Khatun ma'am, and present of my other respected teacher and my dear student. Take my cordial love and salam to all. Assalamu alaikum. First of all, I would like to introduce myself. My name is Lima, Diploma in Midwifery third year, Nursing and Midwifery College, Bogura. Now I am going to start peer teaching class, where the other peer teacher in my group is Musammad Brishti Khatun. So may I start my class, ma'am?
Okay.
So let's start about my topic on PPAs. Objective: at the end of the lesson, the student will be able to define postpartum hemorrhage, type of postpartum hemorrhage, causes of postpartum hemorrhage, management of postpartum hemorrhage, and complication of postpartum hemorrhage. Introduction: postpartum hemorrhage. Postpartum hemorrhage remains a major cause of maternal mortality and morbidity worldwide. Approximately 500,000 women die annually from causes related to pregnancy and childbirth. Hemorrhage may occur before, during, after delivery of the placenta. Definition of postpartum hemorrhage: any amount of bleeding from or into genital tract following birth of the baby up to the end of the puerperium, which adversely affect the general condition of the patient, evidenced by rise in pulse rate and falling blood pressure, is called PPAs. Types of postpartum hemorrhage: mainly two types: primary PPAs, secondary PPAs. Primary PPAs: excessive bleeding from or into the genital tract after birth within 24 hours is primary PPAs. It can occur and after expulsion of the placenta. Secondary PPAs: excessive bleeding from or into the genital tract after 24 hours of delivery up to 6 weeks is secondary PPAs. Causes of PPAs: mainly four types of causes of PPAs: tone, atony of the uterus, trauma or tear, cervical tear, perineal tear, vaginal tear. Tissue: placental lobe, placental membrane, blood clot, thrombin. Clinical feature of PPAs. Symptom: bleeding per vagina within 24 hours of delivery of fetus. It is usually visible but rarely may it be concealed. Sign of the hemorrhage and shock. Per abdominal examination, we show uterus is soft and facet, height at higher level. Per abdominal examination, we show bleeding either copious or slow wheezing. Management of PPAs. Shout for help to mobilize all the staff. Measure to stop bleeding and to resuscitate simultaneously. A quick evaluation of the patient, whether patient is hemodynamically stable or not, whether uterus is contracted or not, whether a cord is found hanging or not, to stop bleeding, injection argometrins, to ampoule IM or IV. Resuscitation of the patient. IV cannula should be inserted. Mainly 2 wide-bore IV cannula should be inserted. Blood is sent for grouping and cross-matching. IV fluid infusion, ricin oxytocin, blood transfusion, antibiotics, catheterization. Gently uterine massage by left hand if uterus is heavy. Placenta is removed by control contraction. If placenta is removed, not separate, then manual removal of placenta under general anesthesia. If bleeding is not stopped, bimanual compression of the uterus. If bleeding continues, must be excluded coagulopathy. If bleeding continues, patient is taken to OT followed condom catheter if normal vaginal delivery. After gently massage of the uterus, if the uterus is contracted, PPA is due to laceration or genital tract, and then laceration should be repaired. Complication of postpartum hemorrhage. Bleeding may be very rapid, puerperal anemia and morbidity, puerperal sepsis, fear for further pregnancies. Have you any question, students?
Oh,
Thank you.